And with that, I think that's all the housekeeping. So it is my great pleasure to introduce our first session and our first speaker, which is Professor John Norcini, who is from Upstate Medical University, New York. So you all have a pack and you can see his biography, but John won't appreciate me doing this, but I just want to add a personal note. He won't appreciate me doing this, he'll tell me off later. But on a personal note, as a very young baby educationalist, one of the first people I wrote to learn about workplace-based assessment was John, who was in Philadelphia at the time. And he very generously invited me back and I literally camped in his office for a week and probably learned more than I have in anything else. So his generosity shows no bounds. So John has held at that time he was working at the American Board for Internal Medicine. Since then, he's had senior roles at the Foundation for the Advancement of International Medical Education and Research, FAMA. He's authored over 200 publications, has lectured and taught in more than 45 countries, and is still doing the rounds, shall we say, John? He's on the editorial board of several peer-reviewed journals and many, many more things. So it's my great pleasure to welcome John.
Thank you, Linda, for that wonderful introduction. It was very special to have you for that time at ABIM. Very much appreciated it. This is just an absolutely beautiful place. It's unbelievable. This is not at all like where I live. Anyway, what Linda asked me to do is talk about workplace-based assessment, so that's what I'll do. And I'll talk about 3 periods in its development. I'll talk first about the past, where there was an emphasis on measurement. Talk about the current workplace-based assessment scene, which is more focused on learning. And I'll talk about the future. One of the big challenges with workplace-based assessment is implementation, and I'll suggest some ideas around that. So as Linda said, I worked for many years, 25 years, for the American Board of Internal Medicine in the US. And what the board does is it certifies doctors in internal medicine. And the board was founded in 1936, so it's nearly as old as I am. And when it was founded, from 1936 through 1970, it had an oral examination and a written exam. And the oral exam was basically 2 long cases with 2 examiners. So the trainee or the candidate would come in, they would work up a patient, and then they would be asked a bunch of questions by the examiners. By about 1970, the board decided that it couldn't do this anymore. The big challenge was that there were now 2,000 or 3,000 candidates every year to be assessed, and trying to get together all the examiners for 2,000 or 3,000 people and all the patients in one place just became impossible. And as a consequence, the board discontinued the oral examination. But there were other problems with this examination as well, in addition to the feasibility issues. And this young gentleman was one of the challenges in the oral exam. So this is Dr. Jack Myers. Dr. Myers was a brilliant physician and educator at the University of Pittsburgh. And if you were an oral examiner at the time, on average, you passed about 80 or 85% of the examinees, the candidates for certification. Dr. Myers' pass rate was 30%. So he acquired the name Blackjack, Blackjack Myers. And there are stories that may be apocryphal, I don't know, of candidates walking into the room, seeing that Dr. Myers was their examiner and running out before the exam even took place. I don't know whether they're true or not, but the bottom line is one of the challenges with this is it depended on which examiners you got, whether you were successful or not. Second issue with this were the patients. If you happened to get patients that were relatively straightforward, your chances of passing were pretty reasonable. But if you got a patient that was more challenging, your chances went down a bit. So in addition to the feasibility issues, there were issues around the examiners and the patients as well. So back to 1970, the board couldn't do the oral exam anymore. So what it did is it decided to delegate the decision around clinical skills to program directors, training program directors. And each of those program directors was expected to do something called a clinical evaluation exercise. So this was an event in which a faculty member would take their trainee, say, here, run around the hospital, find a patient, had to be a new patient that the trainee had never seen before, told the trainee to do a complete history and physical, to write it up, to come back to the faculty member. Faculty member spent 20, 30 minutes asking questions, looking at the write-up, and at the end of the day made a decision, pass or fail, about the trainee. If you failed, you had another shot at the examination, but if you failed twice, you had to repeat the entire first year of training in internal medicine. So it was a high-stakes event. Oops. So by the late 1980s, the program directors were grumbling about this. It was hard to run around the hospital and find a new patient. The logistics were challenging. The patients thought this was incredibly stressful. And so by the late 1980s, everybody was unhappy about this. But at the same time, there was a bunch of research that had been done that gave us an understanding of what constituted good assessment. And that research led to three kind of rules, if you will. One, once is not enough, one is not enough, and reality matters. So what we did is we proposed the mini CEX. But before we did that, if you looked at the traditional CEX, the trainee was evaluated with only one patient. And one of the things we know is that physician performance, vet performance, human performance is case or task specific. How you do it with one patient or one task is not a good predictor of how you'll do with another. As a consequence, if you want to get a good handle on how someone's going to perform in the future, you need to see them with 2 or 3 or 4 different patients. One is not enough. Second problem was that there was only one examiner, and examiners don't agree even when they're looking at exactly the same thing. There's a wonderful series of studies by Gordon Knoll and his colleagues. And what Gordon did is he made a videotape of one of his trainees with a standardized patient. He got his faculty together in the room, showed them the videotape, but told them they couldn't talk to each other, and told them that they needed to write their evaluation of the trainee down on a piece of paper without talking. At the end of the day, after everybody had done that, he took a poll. He said, how many of you thought that this performance exceeded expectations? Some of the faculty members raised their hand. He said, well, how many do you think met expectations? And some of the faculty raised their hand. And how many do you think are below expectations? And some of the faculty raised their hand. And so Gordon was a little troubled by this, and he thought, this can't be right. Maybe it's just our faculty. Maybe we're just, we don't get along so well here. We're a little crabby. So what he did is he took his videotape on the road and he went to 8 or 9 different medical schools, and he found exactly the same thing at every medical school. So if you want to do good evaluation of someone, they need to be seen by more than one examiner. One is not enough. And finally, in those days, as in these days, no physician does a complete history and physical examination, and most encounters with patients are 10 or 15 minutes at the outside. Most patients are returning visits. They're not first visits with new patients. And as a consequence, the task of the clinical evaluation exercise was unrealistic. So out of this, we proposed the mini CEX. Basically, what happens is that the faculty member observes a brief patient-trainee encounter. They evaluate it, and they provide feedback. The idea is through a period of time, there would be multiple encounters and multiple different examiners. And by the late 1990s, this was the alternative to the traditional CEX in the US. But mini CEX is far from the only workplace-based assessment method out there. Basically, everybody and their pet snake has their own method. But 4 of these tend to form a group that are used quite often as a package. So I told you about the mini CEX. In the next few minutes, I'll tell you about the direct observation and procedural skills, chart-stimulated recall, and 360. And the reason that these are sort of put together in a package is that they touch on all of the competencies of a physician. So direct observation and procedural skills, just like a mini CEX, the assessor observes a trainee in an encounter. No, I know, but they're out of sync.
What's up here is different to that.
There we go. Ah, thank you.
That could be more.
Sorry about that. Basic, oh, why don't I turn this way? So the bottom line with the direct observation and procedural skills is just like a mini CEX. You're basically watching a trainee perform a procedure. At the end of that time, you do an evaluation of it, and then you spend 5 minutes giving feedback. At the end of the day, what you're going to do is have several of these with different examiners, different procedures through a period of time. Third method is chart-stimulated recall, and this was developed by the American Board of Emergency Medicine in the US. Basically, what happens is that the faculty member has a chart or a group of patient notes where the trainee has actually seen the patient and made notes in the chart. So they sit down with the trainee, they look at the notes and see if the notes are complete and if they're appropriate, but they then spend a little bit of time having a conversation with the trainee, asking about what they thought about the patient, what was in their differential diagnosis, what they might do if symptoms were different. So the idea is that there would be a back and forth to be able to get at the reasoning of the trainee. So these are used in the same way, basically these brief interactions, 10 or 15 minutes. Faculty member evaluates the trainee and then provides some feedback. When this method was adopted in the UK for use in the foundation program, in the UK there were cases and not charts. So they changed the name to case-based discussion. So if you're looking through the literature in this area, case-based discussion, chart-stimulated recall, same thing. So all the literature applies equally. Last method is multi-source feedback. So what might happen is that Linda is my supervisor, and she gives me 3 or 4 surveys to hand out to my peers. Surveys ask about things like teamwork, communication skills, and so on. I take those 3 or 4 and I give them to my 4 best friends. She asks me to fill out the exact same survey for myself. Everybody returns the forms to Linda, and then I sit down with her for my interview, for my meeting, and what she says is, Norcini, you rated yourself above expectations on everything. She said, you know, the average trainee in this program just meets expectations. And your 4 best friends, they rated you as below expectations. And she said, you know, in the commentary part, she said, they say you're never on time, you're late, you're not carrying your weight. So she and I can have a good conversation. That conversation will relate to my own self-appraisal. It'll also indicate to me that I should be paying a little more attention to being on time and with my 4 best friends. And so when she repeats this 6 months later, hopefully I will have done a little better, both in terms of my own appraisal and the appraisal of my colleagues. So this gets at a different kind of skill. So all of these have some things in common. The basis for judgment, the evaluation of the performance, and the fact that there's feedback. So the trainee is observed in a workplace activity in one of 2 ways. One is I might be with somebody for a month, and at the end of the month, I do an evaluation of them. So I've seen them on a whole number of different occasions, and I'm reasonably well informed about their behavior. So that's a real strength of this, and it's also very efficient. You know, at the end of the month, all you do is you spend 5 minutes filling out the form, and you've captured some information that's useful. The downside of this is that sometimes folks actually do the evaluations, but they haven't seen the trainee do anything. So as an example of this, when I was at the Board of Internal Medicine, At the end of every month, every resident in internal medicine had an evaluation of their history-taking skills and their physical exam skills. So we did a survey of all the residents in the United States, first-year residents, and said, how many times did a faculty member observe you take a history or do a physical exam? And they said, once, during the first year. So what was happening is that the faculty members tend to fill in the blanks, you know. Linda thinks I'm a reasonable trainee. She's never seen me take a history, do a physical exam, but since I get her coffee in the morning, she's good, and so she evaluates me reasonably well. The alternative is to watch someone in a specific encounter, and that has an advantage in that Linda is forced to watch me do something, and she evaluates what it is she watches. So that's a real advantage of these methods. The downside is that they're really time-consuming because she and other faculty members have to watch me on different occasions. And as a consequence, these are much less efficient than collecting survey data at the end of a month. Second thing is that when the observer evaluates it, there are sort of a couple ways you can collect those observations. One is a checklist, and basically I have a list of things, and if the trainee does the things on my list, I put a check mark next to them. So did Norcini ask about a history of smoking? Yes, no. Did he ask what made the pain better? Yes, no. Whatever. So there's a checklist that gets filled out. The advantage of this is that it saves your time, that you don't need to be an expert in order to do that. Even I can watch an encounter and figure out whether somebody asked about the pain or when it started or what made it better. The other good thing about this is it provides guidance for feedback. So when you sit down with somebody afterwards, you have a list of the things they did and they didn't do, and as a consequence, it drives the feedback in a positive way, or it can. But the downside of this is it misses some of the subtleties in performance. So there have been many times I've talked to faculty members after they've done this evaluation, and they say, you know, the trainee took a history, but they were all over the place. They had no plan. They had no idea what they were doing. They didn't have a template in their head that they were working with. They just asked a bunch of questions, and by luck, they filled out the entire checklist. But I have absolutely no assurance that the next time they see a patient, they're going to be able to do a reasonable job. So that's the downside of checklists. As a consequence, the better alternative, although the more painful alternative, are global ratings. And that requires you. It requires an expert to watch the observation, to actually observe what's going on, and then to use your judgment in reaching a decision about the quality of the performance. Good news is that checklists and global ratings tend to be highly correlated. But when you look at the data, the checklists, not surprisingly, are a little more reliable, while the global ratings are a little more valid. They capture the information a little better because they use the judgment of experts. The third thing about the methods is that after the assessment, they get feedback, and feedback is really the point of this. Feedback drives learning, and we're going to talk about that in a few minutes, but feedback is the biggest driver of learning there is. And as a consequence of all this, you, the faculty member, the evaluator, is actually the method. All those methods are just fancy, they're not rocket science, they're just ways of structuring observation and collecting information about them. The bottom line is a person who's doing the observation is the method. And because you are the method, faculty development is absolutely crucial, absolutely essential. So that's where we were back then, but let's move up to the present. So as the mini CEX was introduced, research began to develop about learning in the workplace. So there was information about observation being infrequent, feedback infrequent, and a variety of other things. And I'll talk about each of these over the next few minutes. The first is, and I don't know what it's like in your settings, but in clinical settings in medicine, observation is unfortunately infrequent. So these are some studies, 2 recent studies. One, clinical skills never observed by an attending. 34% of the students said they'd never been observed taking a history. A quarter never a physical exam. quarter of the students and residents not observed regularly, 2022, and I already mentioned the study we did in the day about the number of observations that are happening. So observation isn't occurring, and if you think about workplace-based assessment, what it does is it forces that observation to happen. Even when the observation happens, however, feedback doesn't necessarily follow. Only 26% of trainees reported receiving feedback. Less than half reported it was at a suitable time, in a decent location, that the faculty member knew what they were doing. Only a third reported that faculty had the skill to actually do feedback and give good feedback. And feedback is absolutely essential. There's a meta-analysis of meta-analyses by this guy named Hattie in Australia. And what he did is he summarized tens of thousands of studies, elementary and secondary education. And what he did is he looked at what are the drivers of achievement. And what he found was that feedback alone was one of the biggest drivers of achievement. There's something called an effect size. Effect size of 1 is a standard deviation. It's this big, rarely achieved in education. Feedback alone is 80 or 90% of a standard deviation. So this is an incredibly powerful tool for teachers. And this is not unique to elementary and secondary education. There are dozens and dozens of studies and reviews of literature and Cochrane reviews indicating that feedback is one of the biggest drivers of learning. So if you think about workplace-based assessment, what you're doing is you're forcing an observation. You're following that observation with feedback, and that feedback is one of the biggest drivers of learning. So let's switch gears here a little bit and talk about studies that go back to the late 1800s, actually. Studies of spaced and massed learning. So if I have an 8-hour course to give, there are a couple ways I can do that. I can get you all together for 8 hours and get it done. That's massed learning. Or I can space it out over 8 weeks. I could do an hour a week for 8 weeks. That's spaced learning. Which of these do you think led to faster learning? How many folks think massed? You can raise your hand. It's okay. Massed or spaced? Spaced? Ooh. Confidence? Spaced? I might as well start with the one that seems to be the winner. Massed? Satisfaction? Spaced? Yeah, okay, I won't even bother with the rest. Of course, you already failed. If you do my 8-week course in 8 hours, what happens is that it's faster. You're more confident because you got all 8 hours at the same time, and you're more satisfied you only need to see me once instead of every week for 8 weeks. But in terms of performance and retention, spaced learning is better. So if you think about workplace-based assessment, what you're doing is you're forcing an observation, you're giving feedback, and that feedback is spaced throughout a period of training because you can't do these all one day, you do them over time. And finally, there's retrieval practice. So there was this great, wonderful series of studies, been replicated many times, by Roediger and Karpecki, these two guys at University of Indiana. And what they did is they took a reading passage, and they gave the reading passage to a group of students, and then they randomly divided the group in half. One group read the passage 3 times. The other group took a test 3 times. Didn't get the results of the test, didn't know how they did, just took the test 3 times. A week later, when they went back to them to give them another test, what they found to their surprise was that the testing group did better than the reading group. And the sort of bottom line here is that it's not good enough just to take things in. You have to practice taking them out again. You have to practice retrieving them. And when you do that, even if you get no other information from the outside, you learn in reaction to what you see. So again, if you think about workplace-based assessment, what it's doing is it's forcing an observation, providing the opportunity for feedback, spaced throughout a period of training, and because it's an assessment, it takes advantage of the retrieval effect. So to summarize, Once is not enough. One is not enough. Reality matters. And this is a real driver of learning. So let's talk quickly about the future, and I'll be done. One of the greatest challenges for workplace-based assessment is implementation. This is the thing that really makes it challenging and has really affected its implementation, its utility. 2020 article about what are some of the challenges of implementation. Logistics is the top of the list. Feasibility is always a challenge in any workplace-based setting. There's often a misalignment between purpose and activity. There's not often a strong alliance between the educational faculty and the trainees. And feedback is not necessarily bidirectional. It's usually unidirectional, and that makes it less effective. So one of the ways of addressing this, I think, going into the future is implementation science. As many of you probably know, it focuses on evidence-based interventions and how they're adopted into the real world. There are studies that I'm sure you're aware of that there have been wonderful findings out of clinical trials that never made it to practice because they can't be implemented. It's not that the science is bad, it's that the implementation of those good ideas is really challenging. This has been applied to education, most frequently in medical education by Dave Price. And there are several frameworks around this that guide research into practice. One of those models is called the pre-seed model, developed by Green in 1974. And he takes all the issues around implementation and divides them into predisposing factors, things like knowledge, attitudes, and beliefs, reinforcing factors like social support, economic rewards, and enabling factors like resources. And I'll talk about each of those in terms of workplace-based assessment. So what are some of the things that make workplace-based assessment work? Well, the first thing and the most important thing are committed examiners. This is all about the faculty, and so getting a group of committed faculty is absolutely essential. It is really important, if it's at all possible, to have longitudinal relationships between trainees and faculty. It may seem apparent to say this, but it isn't always, that examiners who have the competencies they assess are better than those who don't. In medicine, the physical exam is not held in quite the esteem it was maybe 40 or 50 years ago. And as a consequence, there's some very pretty papers about examiners without great physical exam skills and their evaluations. They're not exactly where they need to be. And it's also good to have, where possible, the use of patients and other healthcare providers, especially in multi-source feedback. It's really good to have a good peer group, as well as other healthcare providers that can contribute to the process. In terms of reinforcing factors, training, it's absolutely, as I said, it's absolutely essential that some sort of faculty development occur. Unfortunately, as we've done faculty development in the past, what we've done is we've gotten people together and we've beaten on them until they agree. And that's not such a good idea. There are good reasons for experts to disagree in an area, and there are bad reasons for them to disagree. And the purpose of standardization is to get rid of the bad sort of reasons for disagreement. So, for example, faculty members not unusually will say, if two people disagree, well, I rated that trainee as though they were at the end of the first year of their residency, even though they're only in the first month. And the other faculty member will say, no, I rated them because they're in the first month, and that's why I didn't give them. So you want to get rid of those kind of things. That's a silly reason for folks to disagree. And that's really where you want to focus the standardization issues. It is also important, although relatively rare, to monitor and provide feedback to the faculty members who are actually doing the evaluations. For a while, I was a consultant to the Board of Ophthalmology in the US. We had an oral exam, and the oral examiners would always find that, like Blackjack Myers, They had one person who was off the beam, or a few people were off the beam, but they never bothered to tell the person that they were off the beam. They never bothered to give the person information indicating that they were much harder or much easier than other people, than other examiners. So what we found is if you just give examiners information about how hard they are, anonymized so they're not embarrassed, it makes a big difference in their performance. So providing feedback for examiners is really a key piece of this. Feedback to faculty members is really a key piece, and feedback from the trainees is a really important part of that. Finally, there is always a Black Jack Myers, and as a consequence, at some point, it's a good idea to counsel that person to spend their time in other productive endeavors. So lastly, in terms of some enabling factors, it is important to create a system of assessment. You can't be thinking about these as one-offs. You need to think about them as a proper system. So there have to be clear values, routine encounters, support from leadership, all those kinds of things. And other faculty incentives matter. So giving people time, protected time, to actually do assessments are really critical. If you have money, money always works, and that's a good thing. And recognition is important. The folks in the UK and the Academy has done a really wonderful job working with certificates and other recognitions of faculty members who do the right thing and who have some training. So they're all good strategies for making it work. So to end, for good measurement, faculty is workplace-based assessment. Faculty is the key. It has to be more than one, and it has to be more than once, and the tasks need to be realistic. Workplace-based assessment is the best tool you have for learning, perhaps. It is absolutely critical, and implementation is a challenge that I think you can address systematically. Okay? Good.
Thanks, John. Sorry, I don't have a mic over there, so I've come over here. Has anyone got any questions for John? We've got a roving mic coming towards you.
Yeah, I think you raise a really important point. You can overcome some of the limitations of the workplace, and in some instances, as you say, the workplace is, the number of people are so small, you know what's going on. On the other hand, I think that it is important when you do workplace-based assessment to separate what you're going to use those assessments for. So some, if you use them just for feedback purposes, called formative assessment sometimes. So you separate those assessments from those in which you're going to make a decision, summative assessment. So it eases that problem to a small degree. It won't ever make it go away. But at least in separating those two things, you're clearer what the purpose is. And you also, in terms of the person who's receiving the feedback, if you're giving me feedback to make me better, my feeling about that is going to be different than if you're giving me feedback based on something you're going to use to make a decision about me. Okay, I'm going to be much more defensive, and I'm not going to listen to the feedback as much if you're making a decision around it. Separating those two things is really important. But the challenge, you can't overcome one person. I mean, that's unfortunate, but it's true.
Thank you very much. You may have answered a little bit my question, or you've touched upon it. So I would like to see your views on the conflict between being a clinical coach, but also being an assessor, is what you were referring to just now. If we are thinking of, you need to establish a relationship of trust, in a way, between the trainee and the assessor, but I think there is a conflict there. So I would like to see your views, or what do you think about the conflict between I'm giving feedback for coaching, but I'm also assessing?
I think, again, I think you're right on target with that. If there's a possibility, what some training programs do is that they establish a mentor for the trainee who is different than the people who are actually doing the evaluation in the field. And they create a committee even around that. So that's one strategy for separating those two roles. But when those two roles are together, it's incredibly hard to do well. And the only thing that I think is even modestly effective is to be clear when you're giving feedback and when you're making a decision.
Hi. Thank you. Love the talk. Thank you very much. I just wondered if you've cracked getting people to undertake more retrieval and rehearsal, because in my time supporting learning from young children right up to adults in the workplace, getting people to get into that mindset of retrieval and rehearsal over writing, over reading is a tricky thing to do. So I'd love to hear if you've got some tips.
Yeah, so I don't have a lot of tips for that. I think that is one of the things that you can drive, however, because anytime you give somebody any sort of an assessment, what you're doing is you're forcing a retrieval. So sort of scheduling those, making them available. One of the challenges, unfortunately, with formative assessment is that students many times are not interested in it. They don't want to be bothered. We've created a culture of assessment where it's a punitive decision-making process. And so trying to change that culture is really a challenge. And I'm not smart enough to know exactly how to do that.
Your comments about the perceived competence of the assessor were really interesting. And I guess if we look at medical screening, every measurement that is made during screening is logged. Each individual person making that measurement will have that result recorded. They'll have a regression. If they're outside the expected tolerance, they're then no longer able to perform that screening. I was wondering whether you've seen examples of where we're doing that with assessors, and if you have seen examples, why that's not more embedded in how we manage our pool of assessors.
Yes, because at least in the medical world, you're really at the mercy of the assessors. Because much of that assessment occurs in clinical settings without academic faculty necessarily being available. What ends up happening is that you need to cater to the assessors. And as a consequence of that, you take what you can get because that's the best you're going to do in that setting. So that's the one issue. The second issue is, as you said, there are a whole variety of strategies that you can employ that will help those assessors be better. And just giving them feedback, having the trainees provide them feedback, collecting information that's relatively efficiently done can make a difference in that area. But there is no paragon of virtue out there.
Thank you. I think we've just got time for one more, so I'm going to be cheeky and jump in myself, John, if that's all right.
Yeah.
So you mentioned at the beginning that for workplace-based assessment, ideally you need more than one assessor. And thinking about your comments about implementation science, so it feels like one of the areas that workplace-based assessment with feedback can be most useful is in postgraduate training, formal training, in the veterinary context perhaps, specialty training, internships, those kind of one-to-one apprenticeship models. So there is a challenge sometimes, perhaps in smaller practices, to get more than one faculty member or assessor. So how do you square that circle?
So in some instances you don't, okay, because you can't. I mean, if the world is what it is, and you can't make a difference. The other thing that some folks do is that as they rotate through different clinical settings or through different experiences, this is done at each of those places, and as a consequence, over time, you have evaluations based on many examiners and many patients. So the idea is over time, hopefully you can get that. But if it's one-on-one and that's all it is, that's all it is.